Okay, we're going to continue with part 2 with pediatric respiratory dysfunction, chapter 40. Okay, so first let's talk about influenza and the pathophysiology about it. It's commonly known as the flu. It will require large droplet contact precautions, occurs most commonly October through March, and it's most severe in infants. It's usually caused by the orthomyxoviruses types A, B, and C. Clinical manifestations include dry throat and nasal mucosa, dry cough, photophobia. We have myalgia, fatigue, fever, chills. And then, of course, treatment generally is therapeutic management, such as symptomatic treatment, Motrin or Tylenol for fever, encourage fluid intake. Then we have pharmacotherapeutic management, such as amantadine. It needs to be administered within 24 to 48 hours of onset of symptoms. It's only effective with type A flu. It's not curative. It just shortens the duration of the symptoms by up to 1 day. Then we have amantadine, only effective with type A flu. It cannot be used in children less than a year old. Must be started within 48 hours of onset. Then we have zanamivir. It's used in children ages 7 and up for treatment of flu. It's used in children ages 5 and over for prophylaxis. It must be started within 48 hours of onset, and it's effective with type A and B influenza. Then we have Tamiflu. That's used for any age of child. Must be taken within 48 hours of onset. It is effective for types A and B. And then we have both of them, the zanamivir and the Tamiflu, that are recommended over the Symetril and the Romanidine, and it's due to the increased resistance to those drugs. Now we're going to talk a little bit about prevention. Influenza vaccine is recommended for children ages 6 months and up. It's contraindicated for patients that have allergy to eggs, more specifically the actual egg protein. You want to look at page 1204 in your textbook for additional information regarding vaccination for influenza. And then, of course, the nursing care. Care is basically similar to the care that's provided to any child with an upper respiratory infection. These are just a few images that depict, how the flu is administered, except for the cartoon, of course, up to your right. Okay, so a brief anatomy of the ear. We have the outer ear, the middle ear, and the inner ear, and of course you have the cochlea, the semicircular canals, the auditory bones, and then of course the tympanic membrane, also known as the eardrum. We have the ear canal, the eustachian tubes, and the mastoid process. Now, of course, the anatomy for an older child is similar to the adult ear anatomy. We have the eustachian tubes, the cochlea, the vestibular cochlear nerve, the semicircular canals, the pinna, the auditory canal, and the lobule. You notice it's basically the same, but in the makeup of the tissues and everything is quite different. So we're going to talk about otitis media. Pathophysiology. It's usually caused by Streptococcus pneumonia, H. influenza, or Moraxella catarrhalis. Some of the predisposing factors are upper respiratory infections, allergies, Down syndrome, cleft palate, attend daycare, exposure to secondhand smoke, or bottle propping. What it is inflammation in the middle ear. It's usually caused by malfunctioning eustachian tubes. The eustachian tube actually protects the middle ear, provides the drainage, and equalizes the air pressure. Infection of the throat can easily spread to the middle ear and the mastoid. So we're going to talk about some signs and symptoms. You're going to look at box 40-6 on page 1205 of your textbook. Some of these signs and symptoms of ear infection can actually include rubbing or pulling at the ear, rolling the head from side to side, hearing loss, loud speech, inattentive behavior, articulation problems, and speech development problems. So, for treatment and nursing care, there'd be antibiotics. Amoxicillin is the drug of choice. Secondary antibiotics may include amoxicillin, clavulanate, zithromycin, and or cephalosporins. They may receive IM ceftriaxone if the causative organism is highly resistant, pneumococcus, or if the parents are non-compliant with therapy. They may need topical pain relief drops. You want to look at page 1206 of your textbook for antibiotic prescription information. Then we also have surgical treatment that could be a potential. We have the myringotomy, which is a surgical incision of the eardrum, alleviates severe pain associated with acute otitis media. If you want to provide drainage of the infected middle ear or to allow purulent drainage to flow into the external ear for culture. They could also have a tympanostomy tube placement. This is a treatment of recurrent chronic acute otitis media. Pressure equalizer tubes, also known as PE tubes, or grommets to facilitate continued drainage. You want to promote healing of the tympanic membrane and prevent scar formation. It's inserted to treat severe eustachian tube dysfunction or otitis media with effusion or complication of otitis media. It's recommended after a total of 4 to 6 months of bilateral effusion with a bilateral hearing deficit. So prevention. You want routine immunizations with pneumococcal conjugate vaccine, also known as Prevnar 13, as well as influenza vaccination. This can reduce risk factors. Plus, you need to reduce any other risk factors such as smoking. Okay, so for nursing care, reduce the pain. Administer analgesic drops as ordered. You can administer Tylenol, Motrin for pain or fever. You want to facilitate drainage when possible. Clean the external ear with sterile cotton swab coupled with an antibiotic ointment. Ensure that ear wicks, rolled gauze placed in ears after the myringotomy PE tube placement are loose enough to allow for drainage to flow out. And you want to prevent complications or recurrence. Make sure you educate parents regarding antibiotic therapy. Stress the importance of completing the therapy as prescribed, holding the infants upright after feedings, keeping the immunizations up to date, and avoid propping bottles. Okay, so for a couple of nursing tips, before you instill eardrops in infants and children that are the age of 3 and less, you want to gently pull the pinna of the ear down and back. In children over the age of 3, gently pull the pinna of the ear up and back to straighten the external auditory canal. Now let's talk about infectious mononucleosis. It's a herpes-like Epstein-Barr virus. It's self-limiting. It's common among adolescents and is transmitted by direct contact with saliva, hence the nickname the kissing disease. So clinical manifestations that you're going to commonly see um, are located in box 40-7 on page 1207 of your textbook. The test that you may run will be a monospot or a rapid sensitive, easy and inexpensive test. Treatment in nursing care will include for therapeutic management. There's really no specific treatment. You can give Tylenol, Advil, Motrin for headaches, encourage rest, avoid contact sports. Prognosis is usually self-limiting and uncomplicated. Nursing care, you want to provide comfort care, advise adolescents to limit exposure to persons outside their family during the acute stage of mono. And then, of course, look at See Nursing Alert on page 1208 of your textbook. This concludes Part 2 of Chapter 40 of the Respiratory Dysfunction in the Pediatric Client.